I'm Veronica. I'm with Broad River Rehab, and I go around doing ADL documentation classes. Refresher for some of y'all, if you've been a CNA for a long time, things that you use all the time to document. So I will go over what's on the front of the page and then the back of the page. And at the end, if y'all have any questions for me, feel free to ask me. So we have big idea number 1. Code would actually happen during your shift for each resident. Big idea number 2. Code the most you're doing during your shift for each resident, even if it only happened one time. And then big idea number 3. Never miss a 2 paid person assist. If another CNA, a therapist, or a nurse needed to come assist you to get the ADL done, make sure we're documented that it took 2 or more people to do so. Take credit for the work and the care that you're providing. For our residents, it's a lot of work, it's a lot of care, and documentation is a reflection of that. So if you're not documented, it didn't happen. It's also for your facility to get reimbursement for your residents, for you to get paid, and this is how they measure staffing needs. On the bottom of the page, we have our 4 late loss ADLs. This one's our main big ADLs we need to be documented on. We have bed mobility, how resident moves to and from one position, turns side to side, and positions body while our bed or alternate sleep furniture. A recliner and a jerry chair. If they're in one of those, it would be bed mobility. Then we have eating, how resident eats and drinks regardless of skill. We do not include the eating or the drinking during medication paths, but if they're getting nourishment by other means, like tube feeding or IV fluids, that will go under eating as well. Then we have our transfer, how resident moves between surfaces, including to and from the bed, the chair, the wheelchair standing position. We exclude the transfer from the bath or the toilet because that will be documented under toilet use. And that's how resident uses the toilet room, commode, bedpan, or urinal, transfers on or off the toilet, cleanses itself after elimination, changes pad, manages ostomy or catheter, and adjusts clothes. We do not document what we do with it after. It's how the resident uses it, not what we do with it after. On the back of the page, we have our definitions. This is what we use to document our big ADLs. So we have independent. The most you did was nothing. You didn't see it, you were not there. If you're documenting someone that as independent, that means they got the ADL done on their own. You were not there to see it get done. Then we have supervision. It's oversight, encouragement, or cueing. The most you do is watch or cue them. You did not touch them. So if you're walking, let's say you're walking me down the hall and you're just going with me, just to stand by in case, I need you. We have limited assist. If the resident is highly involved in the activity, you provide guided maneuvering of limbs or other non-weight-bearing assistance. The most you did during your shift was touch them to get the ADL done. Some of our examples is you guide them, touching them to walk them down the hall. So if you're walking me down the hall and you're just standing there, making sure that I was okay, and I get a little wobbly, and if you put your hand behind me, that turns to limited assistance. If you adjust their clothes after they toilet, like zip or unzip their pants, tuck in their shirt, pull up their underwear, that's also limited assist. If you have residents that can get from the bed to the bathroom by themselves, You don't have to help them do anything. But if they call you in there because they need help, they forgot something, and you need to bring them into the, whatever they forgot, to the restroom, then that turns to limited assist. That means you assisted them with something. Then we have extensive assistance. If resident is still involved in the activity, but you provided weight-bearing support. And it doesn't matter if it's a lot of weight-bearing or just a little bit. Once you lift, it turns into extensive assistance. And I always say, open your hand, that means you're lifting something. A leg, an arm. So open hand, limited assist. Open hand, extensive assistance. Our examples are, you lift a drink to their mouth to get them to drink more. You lift a bite of food to get them to eat more. Even if it only happened one time. Sometimes you have the residents that you have to get them started. You have to get them going. If you have to give them that first bite, that turns into extensive assistance. Even though they can do it on their own after that, but it's the most you're doing for your resident. So, will you come up here and help me? Yeah. All right. Let's say you're transferring me. Okay. And we're doing supervision. So, I'm getting up, and then I get a little, going to pull up. So that turned into what? That was what? Yes. So that I get going, but then I'm like, whoo. And then you're gonna grab, yeah. So that's, what was that? Yes. So what are you gonna document for your transfer? Right. And even if that's not, 30 minutes before you transfer them and there was supervision, 30 minutes after, you have it. Our residents change constantly. So always make sure you're documented the most that you're doing for them. So you might start something at supervision, but the time that you're done with the ADL, you might be doing limited assist or extensive assistance. And then we have activities in our total dependence, That means you are providing all the care for that resident. They're not involved in the ADL. You're going in there every 2 hours or as needed to check, position, or do pericare for them. They're not doing anything to help you. And they do not, most of our residents that are total dependents do not change throughout our shift. They just stay constant. Then we have activity did not occur. That means you didn't do anything to help the resident for the ADL. You can use this if they're out of the facility or if the ADL did not happen. The one I like to use is the transfer. If you have Mr. Smith and he usually transfers for you all the time when you're here, and today he's like, I'm not feeling too well. Let's wait a little bit before I get out of bed and I get on my chair. But if he does not transfer for you throughout your whole shift, then that would be activity did not occur for that transfer. And that's just a little refresher of ADL documentation. Do you all have any questions for me? No?
What are the late loss ADLs?
Okay. Our late loss ADLs are 4 main ADLs of daily living. So this is what I just went over: bed mobility, eating, transfer, or toileting. Did I answer that correctly?
Yes.
Yes. Anything?
What if you put somebody on a full body lift to transfer? How do you code that?
All right, we just went over this before. So a full body lift is total dependence. That's because you're lifting them, they're not doing anything to help. Now, if you're doing a sit to stand, they're still involved in the activity because you're putting them on there, but they're still grabbing on to push up. So that would be extensive assistance.
How many people should do a full body lift transfer?
I would say 2, in case you don't feel comfortable and somebody else has to come, then you'll.
At least
order
2.
Yes.
Minimum of 2 for sit-to-stand transfers on the lift and for full body lift. Who documents tube feeding?
The nurse.
Who documents IVs?
The nurse.
Yeah.
Is it my turn?
Uh-huh.
I hope most of y'all, some of y'all know me, some of y'all haven't met, but I'm the rehab director for Broad River here at the cottages, so if y'all ever have any training therapy, just let me know. Sammy normally talked to y'all a little bit about passive range of motion and splinting. Passive range of motion, of course, means you are doing the range of motion for the patient. When you are putting a splint on, then you will do passive range of motion for that patient. The things that you need to remember about passive range of motion is if you're having to lift their hand up and they're stuck like this, but they can come up to here, you go to point of resistance, okay? So that means like we have full shoulder range of motion. The patient, you might lift them and you start feeling some resistance here. That's their full range of motion. You go to that point, okay? They don't go as far as we do right now, so you go to a point of resistance. So when you're putting your splint on, just remember that. Splints, the patients that have them, of course, will tell you most of the splints are hand and wrist splints. Sometimes they're color coordinated where the straps go, so they're sort of stuff, but we will start educating you. We do have a restorative aid now, so we're trying to start coming around more when we're putting them on our restorative program and explaining to y'all what's going on, and we will show you how to put a splint on. One thing I didn't tell the first class, if there's any time that y'all do have a splint and y'all don't know how to put it on, or a leg brace or anything like that, please reach out to us. Come get us, call over here, and let one of us show you. We do not care, that is our job. We do not care to help you and show you how to do it so it's on the right way, because if it's not put on the right way, it can cause breakdown and redness and swelling. Another thing to look for with splints and braces is just that breakdown. You want to look for redness, you want to look for swelling, you want to look for, any kind of skin irritation. When you have those splints, it's always 2 fingers. You want to be able to get 2 fingers in straps. If you're putting braces on and they have Velcro, you want to be able to get 2 fingers in between that. If you don't, it's too tight. You need to loosen it up because it can cause all these issues. If you do start seeing those issues, please report it to the nurse immediately. If it keeps going on, then we may need to just discontinue that brace. We may need to order a new brace. A new splint, something like that, so we may need to. Another thing that I told them too, at any time that y'all see a patient and they've had a change, whether their brace isn't fitting them properly anymore, or they were walking but for the past several days they're not walking as well, or they're starting to fall, or they were going to the bathroom and now they're having incidents of bowel and bladder and you're having to change them. Please report that to the nurse, because what she can do is she can send over a therapy referral and have us look at them. So just know that y'all can talk to a nurse for them to refer them to us. Y'all are the ones that work with them every day as well. Y'all know these residents. The thing I like about the cottages is they are so small, so y'all have just a short number to work with. So y'all do know these residents, y'all interact with them daily. So if y'all see a change, please just make sure to let the nurse know so they can communicate with us so that we can take a look and see what's going on. Or if it's a nurse issue, it can be addressed too, so we can just sort of work together. But anyway, that's all I have to say. But if you, like I said, I'm Hope. If y'all need therapy for anything or have any questions or something's wrong, or need to talk to me about a therapist, please come and talk to me or call over. I'll come to you. Any kind of issues, any problems, we're here to help too. I'll help you. If I'm in a cottage, you need some help, I like to help. I have this scratch my back, I scratch your back mentality. I'll help you because I'm going to need you to help me sometimes. So anytime you need some help, just let me know.
I have a question. What about someone that has hand contractures? What are some of the risks?
Thank you. What did you say?
What are some of the risks for hand
I
contractures?
didn't get that one. Hand contracture. So y'all will see a lot of people sometimes like this. If they don't, we try to issue palm guards if we can get them in there. Sometimes we can order carrots and things if we can get them in there. If we can get something in there, y'all can roll it like a wash rag, just fold it up and roll it and try to put it in there. Some of the things that can happen is you need to look for it. You need to keep them clean, because it will have a horrendous smell. That's probably one of the worst smells I've ever smelled. It will have a horrendous horrendous smell, and it can cause breakdown. You need to make sure the nails are cut. You know, if you can't cut them, talk to your nurse, because they will start digging in to the skin and start having sores. Well then, when we start having one sore, we have moisture in there, then it gets a big, huge problem, and so we can't get in there to it. So please just report that to the nurse and check. If you see somebody like that and you're having trouble with them, like I said, ask us, talk to the nurse, so we can get in and look. Maybe we need to order something for them, maybe we could try some range of motion to get in there. But the main thing is you want to keep it clean. When you do clean it, make sure you're drying it good because of the moisture. But please make sure you're cleaning it because, like I said, the smell is horrendous. That's one of the first smells. So just try to keep that clean and dry. And if you do see any issues, any skin breakdown, of course, you know to report that to the nurse so they can start some treatment on that. Okay? Don't try to pull it open though. Like if you can get it pulled open a little bit to get something in there, please do. But don't just keep yanking and yanking because it is very painful for the patients, and we don't want any broke fingers and anybody in trouble. So just please make sure that if you can get something in there, try to clean up under there. Like I said, if it's a major issue, we might have patients that we haven't seen that is like this, and maybe we can look at them and see if we can do something to just let us know. Let the nurse know so we can get a referral sent to us.
It should be slow, gentle stretches.
Yes, yes, like you can't, every time you do range of motion period, whether it be trying to get something in the hand, put a splint on, you are not to jerk a patient open because you can hurt them. I don't want anybody to lose their license because of that. Sometimes it could be an accident, but still, I don't want anybody in trouble for that. So it's a slow, gentle motion. Point of resistance is your key word. So if you've got a hand and you can get it open only a smidget, then you stop there at that smidget and you put something in there. If you've got a wrist here and you can't get it to here, then you stop there. But it's a slow movement. It's not, yanking and pulling, things like that, because you can tear a lot of muscle and ligaments in there because all this starts getting stiff and tone builds up. It's just a long process, and you can actually just break more than a finger. You can really mess up some ligaments and muscle and things. So I just always remember that. Okay? I forgot about that. Thank you.
I was gonna say, thank you. I was going to just go over and try to do like a couple examples for ADLs. So like if you're dressing someone and based on your definition, if you're dressing someone or if you're assisting them with dressing and say they can pull their pants up and everything, if they have tan hose, how would you code that? If you have to lift up their leg and put it
expensive.
yeah. Toileting, transfer, okay. So let's say you walk into the room, hey, Miss Caputo, you're seeing Hay today. How are you? Let's get up and go to the bathroom. And she gets up, she sits at the side of the bed. You don't really have to cue her or anything. She gets up, she sits at the side of the bed, puts her shoes on, she gets up and goes to the bathroom. Okay, so she's going to the toilet, she stumbles a little bit, so you help her sit down. You just kind of guide and help her sit down. And she does her business. You have to help her up off the toilet. Come on, and she pulls her pants up, does everything else. She washes her hands, and then she's ready to go to breakfast. So, thinking of all that I just said, how are you going to code bed mobility?
That would be independent.
What about transfers?
That would be probably limited because if she stumbles,
You had to drive her.
down into the toilet.
So would you code limited transfers under your ADLs?
I would possibly, would that be right?
Well, if you look at your definition, transfer is how the resident moves between surfaces, including to or from a bed, chair, wheelchair, standing position, and it excludes to or from the bath or toilet.
Oh,
So,
it would still be independent.
thinking about everything that you've done during that episode of care, she set up,
She did most of it herself,
yeah,
but she just needed a little guidance.
she set up, probably I would say queuing, supervision, because you came in and said, hey, you know, let's get up and get ready for breakfast and go to the bathroom. Toilet use, how are you gonna code that? Limited because why?
Because you had to guide her to put.
What about when she stood up from the toilet? So if you guide your hands on, but if you have to do weight bearing, your hands under, and you have to help her up, so that would be extensive, right? Okay. So just think, independent is like she said, nothing. Supervision, you're watching, you're cueing, hey, come on, you know, pick up your spoon. That's supervision and cueing. Limited, hands-on, not under, extensive, any kind of weight bearing. You have to lift the drink, like she said, you know. Okay.
Something she mentioned too that I think we forgot this time is patients change day to day.
Yes.
So whereas today you might provide a limited assist or, you know, hardly, you know, anything. Say they fall tonight and tomorrow they can't hardly get up and you're doing extensive assist. So make sure you are not following suit the person that's in front of you documenting. I see that happen a lot in nursing homes over the years. So make sure you are truly doing it. Or say they were limited this morning, but now they're really tired and you're having to really do a lot more assistance. So just make sure you are documenting what you are doing for them, because patients can change and things can happen.
Yeah.
So just make sure
And
you're
it's okay if they change.
right. Yeah, that's fine.
Because in our setting, they do, and it's okay. Now, if you have a concern about the change, please always go and inform your nurse.
Right.
But your documentation is always going to look different for your resident each day or throughout your shift.
Yeah.
Because that's just how it is in our setting.
So the point is, you wanna code the most dependent for each episode of care. So if you went in, you know, 2 hours ago and it was limited assist, you code limited assist transfer, but if you come back an hour later and help them again and it's extensive, you code extensive that time. So code each time, not what you think they should be doing or what they typically do, but what they actually did, or what you actually had to do. What ADL did we miss when I did that scenario? There was something else we could have coded. Hey, Mrs. Caputo, let's get up and go to the bathroom
Relation?
so that we can go eat. So Mrs. Caputo sits up on the bed, she sits for a minute, and then she puts on her shoes and gets up and goes to the bathroom. You have to guide her to sit down because she's unsteady. She does her business, you have to hook her up. She pulls her underpants up, she washes her hands, and then she's ready to go. There's 2 ADLs that we missed, that we had an opportunity to code that we missed.
And ambulation.
There's 3 ADLs that we missed.
See,
Ambulation is one,
grooming,
grooming is, well, hygiene,
hygiene.
because she washed her hands with no cues, nothing. Well, that would be per shift.
That's for sure. What's that other one?
I think ambulation is per shift also.
Isn't it dressing?
Yep, she puts her shoes on. And that could be independent unless staff put the shoes there, then it's set up. But if she puts her shoes like, this is where I put my shoes so I can get to them easy, then it's independent. If staff puts them there because they know like that's where she likes them and she can get to them, then it's set up, assist.
Yeah.
Okay,
So,
so,
what if you scoot?
well, yeah, if you scoot them over to where she can reach them, then that's gonna be set up.
Okay.
if you go in the bathroom and squeeze out her toothpaste, that's set up, that's cueing, supervision.
If she slides her feet in and you're pulling up the back of them because it won't go over her heel, what is that?
That would probably be limited.
Yes.
Yeah.
Unless you pick up her foot.
Yes.
And if you pick up her foot, then
If you're picking up her foot and then sliding the heel in, that is extensive, yes.
Uh-huh. So, if y'all have any questions at all, ever, about ADL coding, about restorative that you might see, and I've tried to kind of clean up the restorative and take a bunch of it off, except for like passive range of motion and splinting. Some people still have transfers and ambulation, but I've tried to clear some of that out for now and maybe we can build that back up again.
Well, what we're trying to do too, what I'm trying to do is like, if we do add some of this other stuff, y'all are already doing it anyway in the day.
Yeah,
So like, y'all already are watching Miss Suto walk from her room to the dining room, so that's ambulation right there if we have an ambulating go. So you're already doing most of this, and that's what we're trying to do.
yeah, and that could be a walk to dine restorative program.
Right.
But you just have to, you have to be there and supervise, because you would have to at least have supervision for the restorative. So if you have questions about ADLs or how to code it, just call me up or send me a note, send me word. I'm happy to help.
I don't mind that help either.
Restorative stuff, I'm happy to help answer any kind of questions you have. Be very, very careful about how you document, and please, 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 please don't put not applicable on things like bowel and bladder. Restorative, don't put it on restorative, because if it's there, it's applicable. If there's a restorative one, yeah. Just be careful how you document, like, certain people, if someone's in a vegetative state and they're total dependent, like they don't move, or if they're paralyzed from neck down, they're total dependent. They're never gonna be extensive, it's never gonna be limited, they're total dependent. People that don't walk, please don't code that they ambulated with limited or extensive assist, people that are non-ambulatory. It's just an issue, I think, of pay attention to who you're documenting, and just look really at your ADLs and the definitions of what they're asking you, so that you'll know what to document. And just don't